Thanks for joining the People of Precision Health podcast, a series by Vibrant Health where we discuss the unique challenges of building human cohorts for health and clinical research. We talk with experts in population genomics and precision health to explore novel methods and real solutions for engaging the humans behind the data. Today, we're talking with Dr. Howard McLeod, who is the Executive Director of Intermountain Precision Medicine and one of the leaders of the HerediGene study, which aims to enroll 500,000 participants. So, Howard, I'm super excited to have you joining us today and talking about the HerediGene study. But the first thing I want to do is get from you just a high-level background. I think most people in genomics research or precision health know your name at least, but tell us a little bit about the man behind the name and a little bit about the study and its genesis.
Yeah, so I didn't start off thinking genetics or the genome would be important. As I did my clinical training, it wasn't important at that point in time, and so I thought, well, it's just it's interesting, but it's a curiosity. During my training, there was some child that nearly died of therapy for her leukemia, and as we tried to figure out why her outcome was so bad, we identified a gene and a gene variant that explained that, and now that's a commonly used test. And a couple years later, a similar thing with an adult with a totally different type of medicine. And so I realized that the genome did influence the way medicines worked. Of course, it had been known that the genome influenced the way diseases occurred. And so I got drug into genomics. So I wasn't where I was necessarily heading, but it was there. I've always been interested in the fun. So how do we have an impact in a way that is enjoyable? And that caused me to make different career changes and such. And one of them was more recently as I was an advisor for Intermountain Healthcare. It's a large healthcare system in Idaho and Utah and Nevada. Now has a presence in Montana, Wyoming, Colorado, and Kansas, a little bit in New Mexico and Arizona. So it's become a 300 hospitals, 400 clinics in 9 states type of endeavor. And as things were moving on, was asked to help them develop something special with their genomics program. And what was developed was so special that as they kept trying to get me to come be part of it, I finally had to say yes, because they really built something that I think has the chance for a lot of different impact. And the HerediGene study, the person who should get the biggest credit for that study is an individual named Lincoln Nadald. Lincoln is a MD PhD out of University of Utah and out of Stanford, and he moved from Stanford back to Utah to Intermountain to start the precision genomics activities here. And he realized that we could do some large population health genomics that would have a research component to it, but also would have a clinical component to it. And as someone who's been at one of the 3 largest genome centers at Washington University in St. Louis, had started an institute that had a precision medicine element to it at University of North Carolina, started the precision medicine program at Moffitt Cancer Center. That idea that you can do research that actually has clinical impact, it was foreign. Most of the research that's done, a person participates and then never hears anything again. And it's designed on that purpose. But what HerediGene built was a way for the population to get involved, and as I'll describe a little later, contribute in terms of discovering new genes or new genes association with the disease, but also get any results back for something that's crucial. So that idea of having an applied approach was really what drew me to be part of this, and now lead this effort across this region.
Yeah. And I just want to remark for a moment on the size, because the HerediGene study aims to sequence the genes of 500,000 participants, and that's incredibly ambitious. And you did just remark a moment ago about the size of the Intermountain system. And I think that a lot of people in research right now are watching this program. So it really is an ambitious undertaking and a very large catchment area that I don't think that most research communities typically think about as a nexus of research, especially genomics research. So I just think it's a really remarkable undertaking. So I wanted to jump right into some of the things we had discussed previously, Howard. And I think I made the comment that when researchers hear the term sequencing, the first thing they really think about is the technology and the processes involved with the sequencing of the samples. They forget about all of the steps along the way to getting the data to be sequenced. And you remarked that there is a lot of infrastructure that you have to build to get to the point of sequencing. And I think you have some really interesting perspective on the challenges that other systems will face because of the challenges you faced. And I'd like to talk about those a little
Yeah,
bit. What
you
are
bet.
they?
It's not a situation where you can go on to Amazon and order 500,000 participants. It's a lot of effort that had to be made. There was if you've ever looked at a road being made, they have to clear the path. They have to then lay some bedrock and then lay some other layers, and then eventually there's a road put on top of that. But there's a lot of effort made to making it so that a road can be there and stay there, and that's really what had to happen and is happening with something like HerediGene. A lot of effort to socialize the idea that one could participate in this. Remember, we're asking people in the population to be part of this study. It's not just people who have cancer or just people who have heart disease or some other reason why they might care. Many of the people that we have involved are fine. They're well. They're there for an annual physical or maybe even not that. And so the idea that they could participate, that genomics has some value, that the concerns around genomics are covered as much as one can be, that there's a lot of things in place from a legal standpoint, from an ethics and moral standpoint. All that effort had to start well before the accrual of participants onto the protocol and the obtaining of blood samples and such. And so that sort of engagement with the community, ranging from the people within the health system to community leaders. There was a while where you could not watch YouTube in Utah without having a HerediGene ad that popped up there and took your time while you're waiting to see those crazy cats and what they did on the keyboard. But the efforts that are there, legislative efforts, making sure that there was clear coverage for people so that badness could not be held against them in some way. That effort had to be put into place, and then from that could go and start enrolling people. And there's been three different ways we've enrolled, but it's either been hi, would you like to participate when you're there at a health center or health fair or wherever it might be. There's been you saw your doctor, you had a blood sample, there's some left over, contact you saying, hey, this is left over. Is it okay if we consent you to be able to use this in the study? And that's been the most popular way forward, surprisingly to me. And then the last one is just digital ads. And so there are people that have participated because they saw the ad, they clicked on the button, they signed up, they then went down and gave a blood sample and went from there. And so, again, lots of effort before we ever got blood in a tube from which DNA could be extracted, sequenced, et cetera.
I mean, and I work with a lot of other programs. I collaborate with a lot of other programs, and it never ceases to, I don't know if shock is the right word, but it reminds me the sheer amount of effort involved in getting one of these programs started. And I don't think we really explored this together previously. What amount of time passed between the idea to do this study and actually getting those ads out on YouTube of cats, which, by the way, I think I need to see one
Yeah.
of these videos because I'm intrigued.
So the first the first year or so, a lot of that was, you know, writing the protocol, starting to socialize the idea, making sure that there was all the people involved. The next 6 months after that was not only going through the process of getting approval for the protocol, but starting to get the ads out there and starting to ramp it up and putting it on the little billboards at the hospital sites and making sure that that people started seeing it. And you know, there's so familiarity is such an important part of participation when it comes to the general public. The idea that you've seen something multiple times makes someone comfortable with finding out more. You know, and we find that if somebody stops me in the street and says, you know, hey, you want to sign this petition, if it's something that I was already aware of, maybe even concerned about, then I'll hear a little bit more. If it's something that I don't have a clue about, you know, I'm sorry, I'm on my way somewhere else. You know, have a nice day. And so a lot of it was around really showing that, and that involved, you know, ads and billboards and that sort of thing, but also interviews on TV. That a number of especially the Salt Lake large television stations had interviews around the concept and really talking about it, and it was either something, a little blurb on the nightly news, all the way through to participation in one of the midday programs where there's a lot of discussion about everything from a new baking idea all the way to, you know, genomic analysis. You know, so the effort that was made was multifold, and it wasn't one person. It would not have happened without Dr. Nadal, without Lincoln, but there were others that had major roles to play. And then, of course, there were a lot of people that had day-to-day roles, you know, that were, you know, there in the trenches, if you will, making sure that things happened in that manner.
Yeah, I can only imagine it was a huge kind of team effort. And particularly when you start thinking about in order to get to the science, we really have to apply kind of a participant focused outreach campaign. A lot of it is marketing and awareness. And I think researchers often get to that realization late. And so I think it's really important to hear you talk about all of the things, all of the tactics that you employed to get to the point where you are today, which is only part of the way. Of course, there's a lot of future opportunity. But I want to ask you a question, a tactical question that's very much related to this idea that you have to do a lot of engagement and marketing, if you will, and that is the comment you made earlier about informing people and really building trust and helping people to know what they're agreeing to, or what we call informed consent. And there's a lot to unpack there. And it ranges from how to know that patients and participants understand what they're agreeing to the technology, to the regulatory and compliance requirements. So I'd like to know a little bit more detail about your approach to consent, informed consent, and what have you learned? What are you going to change, or what are you going to stick with?
Yeah. So ultimately, one can never truly achieve informed consent, with the rare exception of if you or I were consenting, where we had all this prior experience to understand what things mean. Many of the elements that are written in the informed consent are hard to imagine if you haven't been there already. And so, one of the things that we've added are a couple different things. One is videos that help try to bring to life what we're talking about. what this could be used for and such. We've also made it very easy to opt out. So if someone no longer wants to participate, many of the studies that are done at academic centers, where I've done most of my work, it's hard to opt out. You don't even know who to contact, and everything. So we made it very easy where one could go on and without even telling us why, telling us at all, click a button that they no longer are eligible, and that automatically takes their sample out of any further participation. It blocks their data from being used. So there's a lot of infrastructure that was built so that someone could make those changes as needed. The other, and the videos really helped illustrate that was an important part. And then there were people. So one thing we didn't want to do is take a bunch of high school kids or college kids or whatever and say, hey, go enroll people. And I've encountered some folks that were trying to get me to sign a petition, for example, and I said, oh, what is it? And they're like, well, I'm not really sure. And so we made sure that there were people involved so that if hard questions were asked, if somewhat hard questions were asked, they could answer them. And then if more difficult questions were asked, it could be moved up the expertise level to the point where they could be asked that way. And most people will say, oh yeah, I'd like to be helpful, I'm just going to give. But there are some people that want to know all the nuances, and so that making it so that that's not a burden, that there's a clear path for that would be expected in an instance. If everybody wanted it, it'd be hard to accomplish it. But that was the type of thing, and frankly, it's just such a different approach than we're able to take in the academic setting. There isn't the infrastructure to do this sort of thing on most academic programs. You'll notice there's not been an academic university of wherever study like this done. There's now a National Institute of Health study, all of us, that has some overlapping efforts, and is I'm a participant myself, a very, very good program. But if you're really going out to the public, to the population, you have to do things their way, not our way. This is how we do it at the university. If you don't want to do it, then leave, type of thing. And so that was the effort. That was what needed to be put in place. Some of the people we hired to get involved knew a lot about the process and very little about genomics. So we got them up to speed. But we needed people who knew what they were doing in terms of engagement with the public.
Yeah, I think that's really a critical piece. And something you said to me in a previous conversation was, how do we make genomics normal to people? How do we make it not scary and not too edgy? And I think that it's important to remember that participants, that patients, we got to meet them where they are. I think you said that. And a lot of the time we have to unlearn some of the things we know in order to talk to the public, because they're coming from a place of, they're concerned about their information. What are you going to do? And I love this fact that you have incorporated more video. I think that that's a powerful tool to help engage and educate. And withdrawing consent, I think, is also something that really proves to the public that they're not just a participant, they're a partner. And so if they need to or want to take themselves out, that is supported. So very valuable thoughts. Are there any things that you still want to change about your informed consent process?
So we're always trying to update. One of the things that we're doing now is trying to engage more with the participants. Some people want to be engaged with, some people don't. So you have to let people be choosing. But one of the things about informed consent is that it should change over time, because the information changes over time. And so how do we make it so that informed consent or the participation is more of a living environment where as we learn new information, it's shared. As they have changes in their way they approach life, it's shared. The way I thought about things when I was single versus when I was married versus when I was a father, quite different. There's elements that's the same, but the things that have changed. Every participant's going through life, and so there'll be changes. And so we're working on how do we engage with people in a way that's not too cumbersome, because nobody wants to spend all their time with us. But on the other hand, allows them to get more information and to learn more. And we're part of that is going to be engaging with them about what sorts of projects we should be doing and diseases that we should be going after, and do a little crowdsourcing around that. Crowdsourcing in a couple of ways. One, in terms of here's 20 options, what should the priorities be? And that'll just be opinion of whoever votes, something like that. But also crowdsourcing as in, have you ever had trouble getting 8 hours of sleep? Well, okay, that's most everybody. And then start digging into why, and start getting very clearly phenotyped people about those who have trouble sleeping when they should not have trouble. I mean, there'll be some who have trouble sleeping because they drink a Red Bull before they go to bed. There'll be others where, they do all the right thing. They're not using their phone. They're not doing all the things that I do that makes me not sleep well. But rather, and then now we can go in and make a discovery, make an association in a much clearer way, because it's not just, yes, I have trouble sleeping. It's, much more finely phenotyped. And that's been a big issue for a lot of genomic discovery. A lot of it has been risk of diabetes, no risk of diabetes. Okay, we start there, and but now you have all the nuances of different types of diabetes. There's argument around whether there's maybe a third type of diabetes because of COVID. The viral attack on the pancreas is causing a different kind of diabetes than type 1 or type 2. So here's type 3 diabetes, if that becomes the word. There's all sorts of things in terms of you have people who have well-controlled diabetes and yet go blind. You have people who have terribly controlled diabetes and keep all their limbs and all their sight, all their kidneys, and everything in between. And so that we're only going to get to that if we go beyond the electronic medical record and engage with participants. And so we're looking at engagement as part of the informed consent. They now know what we're finding. They now know what we're not finding. Try to get that part. But then also give them a chance, if they want, to participate a bit more going forward. And, we're even thinking through, what do we do to engage with them further? I mean, we now have 170,000 people that are part of this program, and it's increasing by about 7,000 to 10,000 per month. Well, that is a big group. And so if 10% of them showed up for a live event that we had, we would have to have the biggest stadium around, at least the biggest basketball stadium. So we've got some serious number of people. And so what do we do? How do we work with them? How do we make it so that we can fulfill their dreams about these areas?
Yeah, and that is a huge number of people already. And it's a huge opportunity, especially as we start to think about precision health and the reality that to get to a real application of precision, we need those big data sets. We need those large numbers of participants, and not just the clinical data, the genomics, but all of that phenotypic data. And that data collection needs to be scalable and capable of supporting those new questions and the questions that you want to explore and your teams want to explore. But the point you made about engaging the patients and participants of the program more effectively, and this came from the research paper or the publication that you published on your program. We will share that in the show notes as a resource and make sure that anyone listening can review it as well. But this came from that paper. You and your co-authors indicated that communicating effectively from an infrastructure standpoint is a challenge. And I think many research teams treat it as an afterthought. They think about communicating later down the road. So, what was your approach prior? Obviously, you have goals for the future, but what did you do in your first tranche or your first phase of the program, and what did you learn, and then what advice do you offer so that others can learn from your mistakes or your big wins?
So I would recommend working with professionals. What I mean by that is too often we'd say, we'll assign one of the graduate students this job, or we'll assign someone. We worked with our marketing and communications team, who are people who are highly trained in these concepts, to get out there and work on it. And we had to work with them because there was things they wanted to do that we think wouldn't kind of meet the goal. And there were things that we wanted to do that they knew were ridiculous. And going to, but these are folks who are professionals. They are really good at doing this. And too often research, especially academic research, has not engaged professionals. We haven't had enough money to. We've tried to do as the cheap way we can. We will get people who are learning, graduate students or such, to be involved and do that. In this case, and so they brought in techniques, approaches, a wealth of lessons learned to how do we engage with people in a more meaningful way. And so many of the things that we've done, I would not have known to do. In retrospect, I knew that they were a thing, but because I participated in that. I've seen that before, but it wouldn't have been what I thought of to do. And so that sort of thing, where assume that there are professionals out there and that you can work with them, and you have to pay for them, but that was the big difference compared to what I've done previously, is having these pros. And these folks were able to a lot of what I'm talking about getting the communications, the socialization of that, was because of their tools. Whether it was videos, the approaches, some of the meetings, some of the forums that we've had online or in person, they help drive that in an effective way. And there is a science to communicating. It's just that most of us aren't taught it. And so I've been taught a lot of things about biological sciences, but not enough about communication sciences. So,
or we're taught the wrong things.
Exactly. Yeah, I've had plenty of that too. So I think that was the main thing that made the difference, is not just having people involved, but having the people who are professionals involved.
Yeah, I think that's a critical point, because so many research programs don't think about, and it gets back to your point about meeting people where they are. You need to spend the time understanding who you're trying to engage in the community and understand where they are coming from, so that you can then learn to communicate with them in a way they feel supported, feel like they can trust you. And I think that is not only important in the beginning, getting consent, but as you are highlighting, during the data collection process, which can go on forever. This can be a lifelong partnership, I think is a phrase you used in a prior conversation with me. But especially as we start to try to gather more information, collect more data about them, the phenotypic data, and keep them engaged in the program. You also mentioned something previously. We spoke about returning results, and this is something on every genomics researcher's mind. At least I think it is. And I think as you're building trust, that's more critical than ever when you're collecting genomic data, because there's the expectation that they will see you do something with it, even if it's just sharing what you got. So I'd really like to explore that too, as we're talking about engagement and communication. How are you communicating results today? And what are the main challenges you're seeing that you think other programs will see too?
So I'll focus initially on the point of the spear, if you will, the folks who have what we consider urgent findings. So there's a subgroup, and some of those are genes that are on the list that the American College of Medical Genetics and Genomics has put together. Um, Added a few extras that we think there, but these are things where if we find that there is a what's called a pathogenic variant, a variant that's known to cause problems in a gene that's urgent, it causes a big issue, we contact that person right away. So all of the patients have consented to allowing us to communicate with them, typically by multiple means. So it could be text and phone and mail, good old fashioned, or emails usually, but even good old fashioned mail. But the idea that we can communicate with them. So of the first 25,000 or so patients, there were 3,900 plus that had something urgent. And these ranged from breast cancer, colon cancer, ovarian cancer, pancreas cancer risk, um, through to iron overload or genetic hypercholesterolemia, high cholesterol based on genetics. And you can't out exercise that. These are things that, lifestyle is not going to be the answer. It's not going to be lots of exercise and good health, because you are genetically predisposed. Through to something with the ominous name of sudden death, where you're at genetic risk for falling down dead. And if you're interested in soccer or football, if you're the rest of the world, you remember the Danish soccer player Eriksson, that Christian Eriksson, that a few years back fell down dead on the field during the Euro Cup, was resuscitated. He's now back playing Premier League soccer, but with an implantable defibrillator in his chest. And so that sort of scenario, we're finding people that have that. And that's the sort of thing that has been incredibly rewarding. Much higher incidence than we ever would have expected. We expected 2 or 3%. We're hitting about 8%. So it's still only a small fraction, thankfully. But 8% of 170,000 is a big number, and that number is increasing by X number per month. So it's a big issue. The problems were identified almost exclusively in people who had no idea. And so that was a big one. There are some patients who say, hey, you have BRCA1 breast cancer risk gene. And they're like, yes, we know. We've had genetic counseling. We've tested. All right, great. But most of them were saying had no clue. We have a video we put out a few months back of a young lady named Maddie. Madison was her real name. She goes by Maddie. 25-year-old, recently married, participated in HerediGene just to be a good citizen. We found that she had a BRCA2 variant that was pathogenic. She had no idea. Turns out her dad was adopted, and it's on his side of the family that it came through, and so he didn't know. Her 5 sisters have now been tested. Some of them need to be followed up, some don't. Her dad was tested. He happens to have it. Now he has risks and needs. Well, what happens next with those people? So returning results to me is not, here you go, good luck. It is, let us help you as you start this journey. Now, Maddie, this 25-year-old starting her, I thought, what a devastating thing to find out. And she said, yeah, I've cried about it. It was not what I wanted, but now I know, and now I can plan out. And it was just so enlightening to me. Eventually she would have found out. She probably would have been in her 40s. Her kids would have been somewhere in the 5 to 10-year-old range. She might have been found when she had metastatic disease instead of, now she knows, can plan for it. We've also started some new clinics to help these folks. So we now have a clinic. Remember, I mentioned BRCA2. BRCA2 puts her at risk for breast, colon, pancreas, and ovarian cancer. It puts her father at risk for breast, colon, pancreas, and prostate cancer. Well, those are 3 or 4 different disciplines you'd have to make clinic appointments for, and they can't communicate with each other well and all that. So we started a clinic. I wanted to call it the Polyorgan Risk Clinic, but nobody wanted a clinic that's acronym was PORC. So we changed it to a less interesting name. But basically, they can be seen in one place that's informed by all the subspecialties. so that they're monitored appropriately. If we happen to see something in his prostate or in her colon, she then goes and is handed off to an expert who's ready for her. And not just someone who's like, oh, that's, I've never heard of this, let me Google it or whatever that might be. And so return of results is planning for medical care, not a piece of paper that they can take home with them, and not knowing what should be done or not. At least in our case, we really felt like return of results needed to be a start of a complete process, that then could help them lead a better life, because they now know and can be informed and go forward from there.
Yeah, and I think that's a really important point. And something you said to me previously, I think your words were, after the diagnosis, it's no longer a genetics problem, it's a care problem. That notwithstanding, I think that this idea that the genetic data can reveal something that in the future does become a care problem, and it really is a lifelong relationship. I think that's really important. That's a future we want. So you mentioned also in that same conversation that you felt that the genetic counselors at Intermountain were really a crucial piece of this story and the success. So I'd like you to explain just a little bit more about how you have been succeeding in making that, solving the care problem with the genetic findings. How have you been able to be so successful?
So solving is a strong word, but
Okay.
we've made some progress. Genetic counselors, for those who aren't aware, are a mix of a genomics expert and a psychologist. My words, not theirs. They are truly genetics and truly counseling. And so they are expert at helping a person work through what these genetic findings could mean for their life if it's pre-testing, and does mean for their life if it's post-testing. And so I feel like this has been a big differentiator for our success, because they feel like they have someone helping them move forward. They haven't had a leg of the journey they had to do by themselves, and they've been able to have an efficient discussion with people who are experts, so they can understand what needs to be done. There are too few genetic counselors on the face of the earth, so we're fortunate to have the ones we have. But that has been made a big difference in terms of being able to go forward. There are some aspects, such as pharmacogenomics, where it's more clinical pharmacists that are key, because the genetic counselors don't know as much about the medicines as the pharmacists don't know as much about the genomics. But also there's a handoff. So genetic counselors are used to handing off to the next practitioner. So they find a risk of hypercholesterolemia. They then know to hand them off to the lipid clinic, to the cardiologist, to a primary care physician who knows and gets some help on what to do. And that sort of clean, warm handoff is really important, because so much of medicine nowadays are a cold handoff. We'll refer you over to a specialist. The specialist doesn't get much context. You meet with them and they are like, sorry, why are you here? And that sort of thing, because we're in such a boutique area, needs to have a warm handoff. If you talk to an internist or a primary care physician about familial hypercholesterolemia, they're not too sure about this. They might want to read up a little bit on it. If you talk to them about managing high cholesterol, oh, we're ready. And so making sure it's like, hey, we got the genetics part sorted out. These people are at high risk. Diet is not going to be the answer here. They need something stronger. Go. They can take it from there and do what they need to do. But genetics is still one of those things that causes most clinicians to pause. They're not sure. They know some stuff, but they know they don't know a lot of things. And so the idea of having this warm handoff, here's what you need, don't worry about this piece, just go. That it makes it a much more attainable thing. Because otherwise, we've had situations early on where we, found a early onset neurologic problem, said, well, and the patient, knew a neurologist. And so it was like, can I see Dr. So-and-so? Sure, sounds good. Dr. So-and-so wasn't ready. They didn't have a clue what we're talking about. They weren't ready. And they weren't wanting to learn. So we learned then, okay, let's make sure we have people who are ready for it. That way they can get the pay. And then after they have a plan, maybe they then get handed off to someone who's close to home who they already had a relationship with. But that's sort of, there's a lot of nuances I've just been talking about that really we had to learn to do and had to put in place, because otherwise you just end up with a big mess.
Yeah. And Howard, what you're talking about is really, it's the emergence of true research impact into precision health. It is not just finding information from the data that has been sequenced and returning it, and like you said, handing it off to somebody and saying, good luck. You really are describing the vision, I think, that most researchers have for their research, but a reality that's very difficult to streamline or build capacity in today, and something that we're all going to be working very hard to achieve. But I think it also illustrates that concept of this building this lifelong relationship with the research participants who are also patients in the health system. But I want to just pivot as we're starting to get close to the end of our time together on a couple of questions looking forward. We've talked a lot about what you've done, what you've achieved, and what you are doing. But I'd like to know what your vision is for how this program, the HerediGene program, is going to serve patients in the short to midterm, next 3 years. What are your big objectives or largest aims for the patients?
So what we've been talking about, the idea we can find things a decade or so before they're going to happen, is a major theme there. And so as we expand that out, we're looking at the urgent stuff at the top of the pyramid. We're gradually moving our way down. I mean, there's about 7,000 diseases known to be associated with genes, so with individual genes. Not all of them are going to be relevant here, but we're gradually making our way down. So once we've got the urgent stuff taken care of, we start getting into things that would be important to know. Some of these are going to be things that someone will not act on, but it'll explain why they've had all these problems over the years. Some of them will be a change where, like, oh, I never knew I can make this change. Now I can go forward in a much better way. But the idea of kind of working our way down the list so that we have that all that can be squeezed out of the genome is there and can be used. The other piece is making sure that it's accessible across the landscape of medicine. So my in-laws go to a small little emergency access hospital. I think it has about 20 beds. And then if something bad happens, they go all the way into Walla Walla, Washington, to the big city to be treated there. And then, of course, something worse, they then go to Seattle or wherever it might be. The idea that the small hospital in Dayton, Washington, can know what's going on in the same way that University Hospital in Seattle does, that's the kind of thing that we're working on. And so amongst our 400 plus clinics are a bunch of really small places, and they're left behind. No drug rep calls on them. No equipment rep calls on them. They are often the only person in their community, so they don't get to go to all the fancy conferences. You wonder why there's a 17-year lag in the diffusion of innovation. That's because no one's helping them make it closer. And so we're now working with a lot of those places. Over the weekend, had a discussion with the medical director at Garfield Memorial, which is a 15-bed hospital near some of the national parks here in Utah. And we're working with them so that not that they need to become experts. They won't know anything more they know now about genomics, except they'll know that certain situations genomics can be useful, and they'll know who to ask. And so the idea that we have now virtual clinics and such that can be accessible for anybody that is has a phone or has access to internet. Now we're able to make it so we're democratizing this stuff. You shouldn't have to go to a fancy center in order to benefit from this. If we're really going to fulfill our goal around genomics, we will no longer be talking about it. It'll just be part of what we do. How often do you hear people talking about bilirubin? The only time you talk about bilirubin is when it's really high. It's like dangerous.
Well, and when you have a newborn,
Yeah,
that jaundice conversation, and that is literally the only time I've
and then
ever
you forget about it unless
uttered
they
that
happen to
word.
need to be under the belly lights for a few days or something like that. But otherwise, it's not. So how do we make it so genomics is something that's just part of how we practice? I remember when CAT scans were big. Now CT scans are just a thing. MRI, oh my word. MRI, MR, big D. PET scans, okay, now it's just something we do. How do we get over ourselves with genomics and make it normal? And that'll mean this. So over the next few years, a lot of what HerediGene is doing is finding things early, helping people out, engaging in a way. But the ultimate goal is making it so that this is a useful tool when it's useful and not pretending anything else. And only applying what's useful, but it's just normal. It's just what we do. Why would we not understand what kind of gas our car takes before we pull up to the pump? Sorry, Dad, I didn't realize it took diesel is not what you want to be saying, that type of thing.
And that, I think, sums it up. And this is important work. I think that the HerediGene study is something that everyone in the research community needs to be watching. Just the vision that you and your team has and the actual successful application of so many things. Very powerful stuff, Howard. Thank you so much for joining us on this podcast. And I'm excited to be sending this around the world. I hope the story and talking about your work and watching what you're doing in the years to come. Thanks so much for listening to the People of Precision Health podcast. To join us next time, subscribe wherever you get your podcasts. And to learn more about how we're helping to engage the humans behind the data, visit vibranthealth.com.